Good morning, everybody, and welcome to the Friday Informatics Power Talk series. I'm very happy to introduce today's speaker, Dr. Robert Turer. He's Assistant Professor of Emergency Medicine and Deputy Chief Medical Information Officer and Program Director in the Clinical Informatics Fellowship for UT Southwestern Medical Center. His Deputy CMIO role is focused in the area of analytics. He has extensive experience in all areas of informatics, including operations, data science, research, and education, including epic building, implementation, and data analysis. His focus is on using data to improve clinical EHR workflow and efficiency, probably other things that I'm forgetting. He also has extensive experience in education with emergency medicine residents and clinical informatics fellows. He directs the fellowship. He completed his bachelor and master's degrees at Vanderbilt, at Vanderbilt University, and including chief residency in emergency medicine at University of Michigan, and he has MS and informatics fellowship at Vanderbilt University. So without further ado, Dr. Robert Turer.
Thanks, Dr. Wong. Thanks for having me. Excited to be here with you all today. We're going to be talking about trends and opportunities in patient portal disparities with a particular focus based on the work we've been doing among Spanish speakers in North Texas, as well as nationally in emergency departments. This work is supported by the Texas Health Resources Clinical Scholars Award, which is sort of like an internal K-type training award here at UT Southwestern from one of the community health systems, which will also be relevant for some of the work that we're talking about. I'm from Baltimore, hence the crab, and have been sort of bouncing back and forth between Michigan and Nashville for a long time. And it started out as a computer engineer and naively thought that I was going to be interested in doing something more impactful by moving to medicine. And that couldn't have been a more backwards perspective because I wound up back in technology anyway. And as everybody knows on this call, this field is very well positioned to make a change once and make an impact 1,000 times downstream. So I came down to UT Southwestern to follow my mentor and get our clinical informatics center off the ground. And when I got here, as Dr. Wong mentioned, I wear a lot of hats, but as many of the students will know or are going to learn and the faculty know, when you first get somewhere, you get in the room and your chair says, okay, well, what are you going to do? And you say, wait, what do you mean? I've been in training for 15 years. You always told me what to do. And so I had started some work when I was a fellow at Vanderbilt, and we'll be talking about some of the extensions of that work in patient portals. And I brought that up with my chair, and she told me, well, look for the disparities, look for the people who need the most help with it, and it'll guide your path. And I think you'll see some of that in the work that we're talking about today. I do want to mention in that light that nothing gets done by yourself. Science is all about collaboration, and there are two collaborators who are really central to the work that we're going to be talking about. The first is Brian Stites, who's a PhD informatician at Vanderbilt, NLP expert, but really has gotten deep into the patient portal literature over the last few years and has worked with me on a lot of the projects, multi-site related and surveys and things like that, as well as my co-PI, Robin Higashi, who is a medical anthropologist and a qualitative researcher who has partnered with me on this training grant, and she and I are co-PIs, and so a lot of the work that we're presenting, we've done together. Similarly, nothing gets done without mentorship, and Trent Rosenblum and Chris Lehman have mentored both of these projects extensively, and so I'm grateful for both of their guidance. So telling you the story that we're going to be talking about today before we get into it, patient portal use is increasing. Patient portals empower patients, but some folks are left behind. And so I believe that it is our duty to intervene and try to address these disparities. And so I'm going to try to convince you that those first two axioms are true, convince you that there is a problem with folks being left behind. In particular, we're going to be focusing on Spanish speakers today and certain groups within the emergency department, and then some ideas about, at least philosophically, where we can go to address this in the future. So let's start with showing you that patient portal use is increasing. Fortunately, this is the easiest thing to discuss For those who haven't used the HINTS survey, it is a data set that is freely available from the National Cancer Institute. And there's a great group of epidemiologists and researchers there who make these data available. And so this is just a graph I put together from their data that looks at the proportion of patients. This is a nationally representative survey who have used a patient portal online. And it is increasing substantially and non-linearly over the last several years, particularly since the 21st Century Cures Act went into effect in 2021. Among this cohort, 41% had viewed notes and 53% had viewed results. So that's the easy part of the story to tell. Showing that patient portals empower patients is a little bit trickier, but I think I'll convince you that that's the case, at least in a generalized sense. Open Notes is based out of Beth Israel Deaconess in Boston, but is really a national collaborative at this point that since 2010 has been working with a goal to improve transparency in healthcare. Knowing that patients often remember very little of what's said during a visit, but then want to be able to reference it later, they have done a lot of work to show that there are opportunities to empower patients through the use of Open Notes and other open tools. Open Notes is sort of a well-established practice, at least in the pre-Cures era. There are more than 150 published manuscripts and more since this slide was put together that basically says that patients have shown that Open Notes made them feel more in control of their care. Open Notes helped them remember what they discussed with their team. It improved engagement during their office visits. It's something that can be shared and looked at and touched and written together. And generally did not cause more worry, in particular because it's usually documenting something that's already happened and a conversation that's already happened. Where there's a little bit more ambiguity is in the open results space because, as many of you know, there are now laws that mandate the fact that patients have to have immediate access to their results as soon as they are available electronically. Now, that doesn't mean that we as health systems have to notify them, and that's sort of a common misconception, but they do need to be available. And so the post-21st Century Cures Act has put us into a more interesting place. We're asking this question a lot of, how do patients feel about getting their test results before their doctor? Is it true that they want their data? Do they want it immediately? Will it make them worry? What if the doc hasn't seen it yet? What if it's abnormal? What if it's sensitive? And what if it's cancer? And so we've taken several steps, though there's a long way to go in understanding these questions. I published a study and Brian published a study that came together to generate a multi-site survey looking at perspectives of patients who have in real time or who have viewed their results and looking at how they felt about the experience in hindsight. So a lot of the previous literature had been this more hypothetical. Do you think you want to get your results? And what do you think you would do with it? This is looking at patients who did, based on EHR data, view their results. And we asked them their perspectives about it. We performed this at 4 sites: UC Davis, University of Colorado, Vanderbilt, and UT Southwestern, with methodological support from the Open Notes Collaborative. And we adapted a survey from those first 2 pilot studies that were at Vanderbilt, where we looked at just COVID-19 patients to evaluate things like, what was the type and result of the test? Was it abnormal or not? What were the reasons for the test? What was your emotional response to the test? What sort of information-seeking behaviors were demonstrated, and what preferences did you have about getting this type of information in the future? And I'm really going to just sort of focus on that preferences piece for this. So 96% of patients wanted to continue to receive immediately released test results. And 95% of patients who received abnormal results wanted to continue receiving immediately results as well. Now, nothing in medicine comes without harms. I think we all know that. There is an 8% of this cohort who expressed increased worry, and those who had abnormal results reported more worry than those who had not normal results. There's a lot of work that's ongoing in terms of trying to really focus this in on the cancer population, but that will remain to be a conversation for another time. The other piece to this is that patient portals are increasingly necessary for modern care. So any of the modern approaches to hypertension, diabetes, and heart failure, anything that requires patient-entered data, practically speaking, requires a portal account because it's the way that we authenticate patients and get them to connect into the EHR system where we then perform everything downstream. It's becoming an increasingly common, and it's an affordable, scalable way for clinical trial recruitment. It's also a really, really good mechanism for patient-reported outcomes and outcome measures. And you can imagine that that's great unless you don't have it. And so then we're going to pivot to the bigger thesis of the conversation, which is who's left behind and what do we do about it? We'll also talk about where. And here's where our floating head starts to become an issue. But anyways, we'll keep moving forward. This paper from Chelsea Richwine, who works at the office formerly the ONC, looked at racial and ethnic disparities using that same HINTS database, the national survey, to try to identify groups who had been offered or used the portal less than other groups. And she identified that Black and Hispanic patients were offered or encouraged to use the portal at lower rates and access the portal at lower rates. And that's what you see on the 3 bar charts from the left. But interestingly, and I don't think surprisingly, among those who were offered and did access, there was no difference in use. So this is an exposure problem rather than, some other intrinsic reason, cultural reason or otherwise, at least for these 2 groups in general who responded to this survey, and suggests that there may be access and awareness issues in terms of patient portal use. One thing that pops up a lot in this literature is that Spanish-speaking patients are far less likely to have a user portal account. The literature is pretty sparse, though. This paper from Ale Casillas out at UCLA used audit log data. Unfortunately, it's pre-cures data, but it's the best data that we have so far, looking at general use as well as feature use. And there was substantially less likelihood of using a portal at all and significantly lower feature use rates among Spanish speakers compared to in all limited English proficiency patients compared to English speaking patients in the same safety net health systems in Los Angeles. And so the goal of our training grant has been to identify barriers to patient portal awareness, enrollment, and use among Spanish speaking patients across 3 diverse health systems in North Texas. And so all of the work that I'm going to discuss related to this grant is joint work that I've done with Dr. Higashi. We used a mixed methods approach, and we really tries to focus on 3 aims. First, we tried to characterize and compare patient portal use patterns in Spanish and English speaking patients using EHR user data, looking at enrollment and feature use, as well as evaluating secure messaging data. Robin has really led the second aim, which is evaluating patient-level barriers to portal activation and use among current Spanish-speaking portal users and non-users, which is all qualitatively based. Semi-structured interviews at multiple sites of both patients and providers, which then move to surveys to generalize the results across multiple sites. We are currently underway in the design and implementation phase of several interventions to try to address these issues. And so we'll discuss briefly the strategies for that at the end, but that remains to be completed. So first, we're going to talk about aim 1, which is our user log analysis, comparing the initial access, enrollment, and use rates between Spanish and English speakers. So there's a quantitative study, observational, using Epic Clarity data, which is Epic's enterprise data warehouse. This took place at 3 sites. Parkland Health, which is our county-owned community health system that provides a lot of the internist care in Dallas County. Texas Health Resource, which is a faith-based nonprofit that provides a lot of community-based healthcare, and then UT Southwestern, which is the Quaternary Care Transfer Center. We included all adult patients with at least 1 face clinical encounter, which means that they interacted with somebody licensed to prescribe. So a physician, an advanced practice provider, a resident, a fellow, somebody like that. The dates of the study were a 1-year window between April 5th, which was the day that the 21st Century Cures Act went live, and a year following. We chose this to allow for a 1-year look forward window through the middle of 2023 so that we could look at outcomes for these patients and see what they did downstream. Our outcomes of interest were portal activation at baseline, so people who at their index visit had a portal account. We looked at those who subsequently enrolled, and then among those who did enroll, whether they and how often they logged in, viewed results, viewed notes, and sent messages. We adjusted all of our models for age, site, sex, comorbidity count, which we define using Elix-Hauser comorbidity indices, generally across the problem list. So traditionally, those are used just for inpatient diagnosis, and we use those same classes and that same knowledge management strategy on all problemless entries. And then we used the number of encounters prior as a surrogate for health system utilization. We started with descriptive statistics. For dichotomous outcomes, we used logistic regression adjusted for the above and standardized to handle patients with multiple visits. And then we use zero inflated negative binomial models for count variables, where we were looking at the amount of logging in, the amount of viewing results, the amount of viewing notes, and the amount of messages sent. So our Spanish-speaking cohort represented roughly 8% of the overall cohort of 1.5 million patients. They were demographically fairly similar, except the Spanish cohort tended to be Hispanic for obvious reasons. 12% of that cohort was commercially insured compared to 48% of the English-speaking cohort, and substantially fewer had portal accounts at baseline. The chart on the left shows a logistic regression model, both with pooled results as well as individual site results, evaluating the likelihood of baseline activation or activation in the next year. And you can see that at both all sites and overall, there were substantially lower rates of activation. Though I will point out that Parkland, which is better geared and better suited to supporting the Spanish-speaking population, given the nature of the care that we provide there. And I work both clinically at Parkland and at UT Southwestern, and can attest to the work that they've done to make things accessible to our Spanish-speaking population. Had less of a disparity, but the disparity was substantial nonetheless. So moving now to logging in and use. So the chart on the left looks at the inflated component of the zero inflated models, which is basically giving you information about whether they logged in at all, reviewed notes at all, reviewed results at all, or sent messages at all. The right-sided figure shows the extent among those who did the thing at all. So for logging in, Spanish speakers were less likely to log in and logged in less compared to English speakers. There wasn't a significant difference when it came to notes, which when you go back to the descriptive statistics, that's because relatively few people compared to results or messages use the notes feature of the patient portal. And that's pretty typical across studies when you look at feature use. There were some site differences, but overall, from a pooled standpoint, Spanish speakers were less likely to review results, though interesting, among those who did, they did it more. And then Spanish speakers were less likely to send messages and sent fewer messages. And some of the qualitative work later, I think, will get to why that may be. We also looked a lot at proxy account use. Prior literature has demonstrated it care partner involvement, so families, friends, and other proxy persons are really important when it comes to the healthcare journey that many Spanish speakers face here in the United States. So this is using the same overall cohort, but we only assessed the patients who had at least one session via an official proxy account. And so setting some definitions. In Epic's MyChart, you can have an official proxy account where you have your own username, your own login, and then you're given credentials to look at somebody else's account. So when I log into my account, I see, but first I have the decision to choose, do I want to look at my content or do I want to look at my daughter's content? And I have to choose, and then I have whatever feature use is delegated at that point. This is in contrast to sort of care partner involvement through the person's primary login account. And this will come up again in a couple minutes. And so very few people from anywhere used a proxy account. So only 4.3% of English speakers who had logged in versus 6.6% of Spanish speakers who had logged in used proxies at all. Again, it is much higher at Parkland, which I think probably goes to speak to some of the efforts that they have contributed. And overall, it is higher among the Spanish-speaking population, highlighting the importance of care partner engagement, especially and often of an English-speaking care partner. But the proxy accounts are not the way that people are using this, and we'll show you that in a moment. We also looked at portal messaging patterns from this cohort, and we looked at the same group who had had at least one clinical encounter and who had sent at least one medical advice request initiated in the portal. And really what this means is one free text unstructured message to a care team member asking for something. And there were two branches to this. First, we did a simple quantitative assessment of the proportion of patients who had sent at least one message via a proxy account. And then we'll talk about the qualitative efforts later. But for those, we randomly sampled 100 patients from each of the 3 sites and then took all of the conversations during the study period and analyzed those qualitatively. So we saw the same thing here in terms of sending proxy messages, sub 2% for all of the sites, and most of them were sub 1%. So very few Spanish speakers who are speaking on behalf of their loved one, who is the patient, are doing so through these official proxy accounts. From a qualitative perspective, some more interesting patterns emerged. So among the 3, it actually wound up being 298 patients. 882 patients had initiated conversations. And from those conversations, there were just under 1,500 messages sent. And these were extensively analyzed, thematically encoded, and then we calculated descriptive statistics to describe the patterns of use. So among patients themselves, and here's where I want to point out the distinction. This is not using a proxy account. This is based on thematic encoding of things that were embedded within the messaging. Hi, Dr. So-and-so, I wanted to email you about my mom. That kind of thing, rather than this being some structured entity that let us know that that was what was going on. So most of the messages did come from patients, and patients themselves messaged in Spanish more often. We didn't really get into that here for this talk, but overwhelmingly, the responses from clinicians are concordant with the patient's initially sent message. And so that suggests that, patients already know in advance that they're working with a Spanish-speaking or bilingual provider before they send the message in the first place. Now, care partners far more often messaged in English, suggesting, at least to us, that that may be something where patients are using their English-speaking family members or friends to help them navigate the system. In terms of what they used the system for when it came to messaging, the 2 most common categories were requesting a prescription refill or setting up an appointment, which interestingly are things that we actually have structured approaches for and may suggest opportunities for education. But I won't read them out loud to you. I'll just give you a second to sort of read through the types of things that people were asking about. But it pretty much runs the gamut of content that people can use the portal for and what they seek their healthcare for. So in short, Spanish speakers are less likely to have, acquire, or use portal accounts overall and at each individual site. Care partners are vitally important for use among Spanish speakers who rarely use proxy accounts. And there are opportunities in terms of patient education to enable patients to use structured features to both save them time as well as to reduce staff burden. So moving on to the more truly qualitative study to understand some of the barriers, and this is really presenting more on Robin's work than my own, but it's important. Robin at Parkland interviewed 14 patients and sought to understand what the barriers were to not using the patient portal. Many people reported that they simply weren't aware of it. And knowing how registration works at many places, if you don't have a bilingual registration person, even with an interpreter, the likelihood that they're going to have time to get into that is substantially reduced. And so understanding how we can address that is going to be important. We'll come back to that during the synthesis at the end. Multi-factor authentication was sort of an interesting thing that came up. This quote, I always get angry with my chart because I'm in a hurry and I want to enter to see what appointment I have with a doctor when the medications are ready. I have to enter the damn code. And I think we can all empathize with that, especially when it doesn't work smoothly. If you're in those workflows all the time, it's not a big deal. But if you're not, it can really be a barrier if you're not comfortable with your device. There was reluctance to use the phone line, even though it was listed. It actually has a pretty good response time, but they just assumed that it would be like calling, the cable company or anybody else, and you wouldn't get anybody on the phone, or you wouldn't get somebody bilingual on the phone. The need for caregiver support to use the app, especially among older patients lacking digital literacy and language proficiency, was also cited as an issue. One thing that isn't listed here, but certainly people have concerns about putting structured information, especially in a state like Texas, with everything that's been going on here recently when it comes to concerns about deportation and immigration status also. In terms of meeting with our clinicians and seeing what their perceived barriers were, they were also not aware that there were Spanish versions and Spanish translations in the MyChart tool. Clinicians and staff reported lack of time, resources to assist patients directly in clinic or by phone, need for dedicated staff. And I'll just tell you anecdotally, even my informatician friends often don't know that it's a 2-click workflow in Epic to be able to get somebody enrolled themselves, not a registration, not asking a nurse to do it, but anybody really in the system can have that power to enable the patient to do so. And I'd love to have some conversation at the end about sort of what the experience has been here from a Cerner perspective, and then sort of as you guys are migrating to Epic, what that might look like, because I think it will be an interesting conversation. And there was a lack of awareness of existing system-level patient-facing tools and resources. There are how-to videos, but people didn't know that they were there. There is a Spanish-speaking navigator. People didn't know it was there. And so outreach to folks who miss telehealth appointments to get them education was also cited as something that might be helpful. Just some demographics about the patients who responded to a survey to try to get some more generalizable results among Spanish-speaking patients at Texas Health Resources. Generally high school or less in terms of education, with a broad range of age and gender. Relatively few people compared to an anticipated level based on reported findings had a MyChart account. A relatively large number of them used it in Spanish. And for context, typically that'll happen based on the locale of your phone, whether Android or iOS. And so that was sort of a promising finding that we weren't necessarily expecting. But a very high rate of folks reported needing help, which is concordant with some of our care partner findings. The most important thing when we asked people that they thought would be a facilitator was easier sign-in, which I don't think any of us were expecting that things like the multi-factor would cause such an issue for people. More functions in Spanish. At least for Epic's MyChart, there are configuration mappings that need to be done to make sure that all the menu items and other facilitated content is in Spanish, which ignores the fact that things like lab results themselves are pulling directly from the lab information system or the radiology information system or PACS, and so those aren't going to be translated, which again is an opportunity for the future. There were issues with jargon and complex language. There were issues in terms of being able to actually receive messages back in Spanish, and then the other comments and requests for Spanish speakers or navigators to help. So in conclusion, we felt that there was a need for increased marketing and education to both patients and staff to make people aware of both the resources that are available and to really help people get through that initial activation and first 3 logins, which we found to be critical in speaking at the interview level with patients to get enrolled. And we reemphasized through the qualitative studies that our quantitative findings resonated, that people really do lean on their families quite a bit to use these tools, and often more than what the literature suggests in prior studies among English speakers. So that's sort of the who is getting left behind and how much they're getting left behind. There are many other disparities that we're not talking about here, and you could talk for an entire symposium on this. But we're going to talk a little bit about the where. When you're a hammer, right, you look for nails, and I'm an emergency doc, and so I looked close to home, in part because there was very little literature on this, and just because it was an experience that I had encountered a lot. Very few of my patients had portals, especially those who aren't already well plugged in with the system. And when I talked to people about things like, hey, why do you keep missing those appointments? They often didn't know, and they didn't know that there was a way that they could know. And I've been surprised, there's some interesting studies out of Fort Worth down the road looking at getting homeless patients enrolled in the portal and how much it has enhanced their ability to get to appointments. And so a lot of the populations that we assume, older patients and other patients that many of us, right or not, implicitly assume are going to have a hard time with the portal, with a little help often can often benefit from it. So that's sort of my motivation. This started as a single site study that then evolved into a multi-site observational study with collaborators from across the country that was facilitated by both some AMIA work groups and the Society for Academic Emergency Medicine Informatics interest group. And we aim to describe real-time patient portal use trends among ED patients to compare demographic and clinical characteristics between portal users and non-users. And when I say real-time, I mean they're sitting in the waiting room, they're sitting in the ED bed, they're getting treated in real time. So this is that this has come up a lot of, hey, will people leave the ED when they see their COVID result? Or, hey, are they going to see their cancer diagnosis before I do because they look at it 5 minutes before I can see their CT? That's the kind of thing that we're talking about here. So there's a multi-site cross-sectional study. We followed the record guidelines for using routinely collected EHR data for observational studies. There were 8 health systems listed here, representing 36 EDs, 12 academic, and 24 affiliated community EDs, all using the Epic EHR. I'll let you kind of take a look at who was involved. So we looked at all adult ED patients during that same time frame for the same reason. These were conducted relatively contemporaneously. And we looked at MyChart, or all of the sites had the MyChart portal available in real time with various levels of promotion. So places like Stanford had been promoting digital health and engagement for years and took big pride in that. And so I didn't include the graphs here, but when you look at the site-specific data, places like Stanford have much more engagement at baseline and have much more feature use, as you'll see, whereas others, including UT Southwestern, were much more new to this approach, especially in the emergency department. We looked at the weekly proportion of ED patients who used the portal, specifically defining that as those who logged in, those who viewed test results, and those who viewed notes. And again, these are patients who are viewing in real time between ED arrival and departure. For admitted patients, we waited until they left the department. We did not include time when they were admitted upstairs. That's another study for down the road. Similarly, we adjusted for age, sex, insurance status, preferred language, ethnicity, and race. And then we tried to adjust for clinical acuity using the emergency severity index baseline MyChart status, meaning whether they were enrolled when they got to the ED. And we reported descriptive statistics, time trends of real-time portal use, and we used multivariable modeling. And we accounted for patients who had multiple encounters by using robust standard error adjustment. So here's the place where I actually am pretty excited about this study. I think the findings themselves, to anybody who works clinically, are not terribly surprising. But what I think we showed here is there is a sweet spot for semi-federated research that allows you to move very quickly, where things aren't quite in a true federated approach in the definition that we use when we talk about machine learning. It's not quite a registry type thing where you have the multi-year process of getting things up and running, a very complicated IRB, data dictionary, and data use agreement process, ignoring any of the technical restraints of getting data transferred in a efficient and safe manner. The way that we did this is we created an IRB that everybody used and tailored just the needed parts to their individual site. We used standardized SQL queries that extracted the data from parallel data warehouses, where only the things that needed to be mapped. So things like insurance status, preferred language, ethnicity, and race are often mapped differently. And so we tried to use standards there, things like the OMB standards for race and ethnicity, and census reported categories. We wound up having to iterate through that and chose English, Spanish versus other. But it really allowed us to move very quickly. And then for our analysis, we used shared R scripts with, again, very minimal setup so that once people got their query optimized, they literally plugged it in and the output was ready to be brought back in for a meta-analysis style approach where we pulled the estimates and standard errors to generate a pooled response. So again, it's one of those things where I think to this group of people who are very statistically minded, in some ways it's not that technically interesting, but boy, it sure saved us a lot of time. And it was sort of a strategically interesting approach to this study that wound up being the most interesting part, I think, in some ways, even more than the findings. Anyways, back to the study. So we enrolled 1.3 million patients, mean age of 51 years, and slight lean towards women. Most patients were white, though there was a wide range and a fairly diverse cohort. There are some groups, particularly American Indian or Alaska Native and Native Hawaiian or Pacific Islander, with very low response rates across all sites. A good mix in terms of payer mix to make inference. And a pretty typical ESI mix. For those who aren't familiar with emergency medicine, ESI 1 is patients who are coming in coding in acute respiratory distress, The one exception that's a little interesting is acutely suicidal often gets assigned a 1 because it's threat to life. In ESI 5 is somebody who really doesn't need a physician evaluation. Most ED visits run 2 to 3, and then urgent care type visits, things like sprained ankles or simple injuries, run in ESI 4. So this is pretty typical for national ESI rates. The admission rate is under 30%, which is a little high nationally, but represents the fact that this is mostly academic or academic affiliate sites. And across all cohorts, there were 51% patients with MyChart activated before they got there. So in terms of time trends, we saw a consistent upward trend in terms of patients logging in and viewing results. If you look at the model results in a minute, you'll see a statistically significant increase in viewing clinical notes, but sort of like with our other study, I don't think you need a model to tell you. It's sort of like, okay, well, I guess we're increasing, but we're increasing from not very much to not very much. So I don't take too much from that finding, but there is both a statistically substantial and I think meaningful trend in the increased use of logging in and viewing notes or viewing results. And almost none of the sites except for Stanford had actively campaigned for this in the ED, which is sort of an interesting finding. We did run a sensitivity analysis without them and it didn't change the results. And they had the same sort of upward trend at their site. They just, it started from a higher baseline. So sort of going through the odds ratio plot and making sense of it, these are the pooled odds. There was increased use over time. We talked about that. There was decreasing use with age. There was a sweet spot of acuity. If you're dying, you're probably not having time to look at your portal. But for people with fairly acute complaints, there was an increased odds of using the portal. Men use MyChart less often. This is pretty typical across the portal literature. Asian and white patients were more likely to use MyCharts. Black patients were less likely. Statistically insignificant results for Hispanic patients, which actually doesn't change much when you look at local results in Texas and California, where you would expect that to be the case. Where you do see sort of some unusual findings were among the Spanish-speaking cohort, where if you look locally, you do see disparities like we talked about in the prior studies. And less use for all non-commercial insurances. Admitted patients were more likely to use, which I theorize is just because they're in the ED longer. And overwhelmingly, the strongest predictor of use was people who already had tools with an odds ratio of 17.73 from a pooled standpoint. I'm going to skip through these slides because they basically say the same thing, but just in terms of results review, you have the same trends in terms of who's reviewing more. And again, for the notes, you have a mostly similar trend, but far more that are statistically insignificant because there just aren't that many people doing it in the first place. So in summary, patients increasingly use patient portals in the ED. I think that information availability can increase engagement and shared decision-making. I think there's a lot of us that have trepidation about this and fear about it. And look, I've gone from one room in the department and had people tell me, you know, when I got my cancer diagnosis, I'm really glad I had the chance to do it before the doctor did because it let me get my tears out and be ready to ask questions. Literally that shift, walked across the hall and somebody said, man, I do not want to deal with this thing. I need a human being to talk to me about this. People are different, their preferences are different, and we need to respect that. Yet there are big opportunities for this. We saw that immediate release for sensitive test results impacts patients and clinicians. And we observed disparities that were similar with the rest of the literature, which especially given the fact that people from those historically medically underserved and digitally underserved groups go to the ED for their care, I think it further highlights that there are opportunities for us to get people engaged, just not with their ED care, but to make them sticky with the health system so that they can get to their appointments, get the access that they need for the information that they have. So I hope that I've convinced you so far that patient portal use is interesting, that patient portals empower patients, but some folks are left behind. In this case, we talked about Spanish speakers and emergency department patients, particularly for medically and digitally underserved groups. But now I'd like to briefly convince you that I think there are things that we can do to help with this. So it's time to transition from identifying, localizing, and characterizing trends and problems to doing something about it. I think progress is going to require top to bottom support from clinical, operational, health IT and informatics leaders. This isn't just going to be medical directors. This is going to require all hands on deck. And you see this at certain places like Lurie Children's in Chicago, where they've really made this a priority and have made incredible strides in getting people enrolled in the portal. Solutions have to be scalable, cost-effective, and sustainable. It's no surprise that if you in our Spanish-speaking example, if you have a bilingual navigator who's there 24/7 and can physically walk around and talk to people, they're going to enroll more. I also don't think it will surprise most of the people on this call that may not be cost-effective, it may not be sustainable. And so I think this group of informaticians, the people on this call, need to be the ones that sort of drive this innovation, because I think we're the ones who are capable of being scalable, cost-effective, and sustainable. So this is kind of jumping back to our grant work that Dr. Higashi and I did. We mapped out sort of the journey that a patient has to go in order to enroll and use the portal. So there's awareness, becoming aware in the first place, getting invited, activating their account, and logging in. And again, really, that's the first 3 logins before you get to the rich part of the experience, which is content review, structured requests, messaging, patient-entered data, and ignoring any of the trial-related stuff. We've highlighted data or the areas where we have data to support that there may be issues. We know that there is an awareness problem based on our survey data and our interview data. We know that there's an activation problem, especially among the Spanish-speaking patients, given the lower activation rates, lower login rates, lower content review, and lower messaging rates. We haven't really dug into this. We have some data and can do secondary analysis, and we similarly have not explored the patient-entered data, which in hindsight would have been a very interesting thing to do, and as a study I'd love to conduct someday. We wound up generating an intervention planner trying to focus on things like feasibility, efficacy, scalability, sustainability, looking at the impact of the groups that are going to be impacted by the work that we're doing, and then trying to map things that would be viable. I'll leave it up for a sec so you can get an idea, but I'll summarize sort of our findings in the context of our flow diagram in the next slide, so don't worry too much about the details. So in terms of awareness, we came to the conclusion that improved marketing is needed, and we're currently working with Texas Health Resources and their digital outreach group to respect the preferences that were identified. And there were some very specific things about the way that people wanted flyers to look. People liked sort of flashy, exciting, engaging flyers, flashy, exciting, engaging digital advertisements, and wanted that to bring them in to get engaged with the tool. Similarly, our staff felt like they needed more information. They needed more focused education to be able to understand what was and wasn't possible and how they could do it without making their workflows more onerous. In terms of activation, we are working through some new workflows, first in the ED as a pilot, and then more generally. So I'm doing that at UT Southwestern, and then we as a group are going to do it at Texas Health Resources to try and get more patients involved, to take advantage of the waiting room and boarding time that people are experiencing all across the country, which is an example of a potentially scalable approach. There are educational tools at Epic called Care Companions, which are sort of serial longitudinal activities that patients can do that involve some patient-entered data, some educational materials that could really help people get through that first 3 login barrier if you can get them over that first hurdle. And then that's as far as we've made it. In particular, because when you actually look at the impact of these barriers, it is far worse up front. So if you're doing more of a QI approach to finding the bottlenecks, we really need to focus up front before we move to the content-specific area. So in terms of the ED side, I think we can partner with vendors and patients. The same Hello World-based approach that I referenced here with the automated activation reminders, we're going to use there, and I think represents a huge opportunity nationwide to increase engagement. I think there are educational opportunities. Patients are sitting there twiddling their thumbs while they're waiting for their results anxiously, and we can empower them. We can teach them what their test results are being sent for, potentially without using any staff time. We can teach them how to use these tools to engage more in their care afterwards so that they know how to get to the follow-up appointment or the referral that we provide in the ED. And I think in terms of a customer satisfaction standpoint, there's a lot we can do in terms of letting people understand where they are in their journey. Hey, we haven't forgotten about you. Your test has been finished. We're waiting on the radiology to read the CT. Hey, we know that you're here. We know that you're still in the waiting room, but your labs are back and a team member is going to review them. There are tons of opportunities for us to engage here. So anyways, I think there's a lot to be done. We are just starting this journey, but I would love to open up the discussion, and I welcome, collaboration now or in the future. So I'll stop sharing so we can see and hear one another, and happy to take questions.
Thanks, Dr. Turer. Great presentation. Feel free, anyone, to either unmute yourself or enter questions into the chat. I may be going a little off scope here. Just wondering, have you thought about the role of AI in any of this, either for tailoring or just improved communication?
100%. So this grant actually started as a machine translation grant. And I got enough grief that it was not implementable that we wound up pivoting to this more implementation science thing. And then like 6 months after we started, the LLM phenomenon exploded. And so we've kicked ourselves a few times for that. We are working on a study looking at things like blue scores and things like that, comparing human translations to LLM and traditional neural net-based translations of messages across languages. So that is one place that has not really been explored. I think at the vendor level, there's a ton of work going on in terms of, I don't remember which institution in the Northeast. I saw a great talk from UT Medical Branch a couple months ago using Epic's new message pre-populating feature to make lives easier for clinicians to message their patients through automatic message generation. I think we're seeing a lot of this with clinical summarization. And so I think it is only a matter of time between the vendors start playing in this space as well as investigators locally in terms of how do we tailor content? How do we, even if we can't legally, ethically, with confidence, translate things like lab results or imaging results, can we at least give culturally tailored responses that are tailored to the individual person's test using either traditional predictive means or generative AI or something like that. So yes, I think there's an enormous amount of potential here. There's probably also enormous potential in terms of finding the people who would most benefit from it so that you're not just peppering the entire population with these invitations, especially because there is some institutional cost to doing that. And you can imagine that nationally that may be a barrier. So if you could find ways to identify people who are likely to benefit using some sort of matched cohort to identify those people, that might be another approach that you could incorporate AI into that timeline.
Yeah, thanks.
Rob, hey man, it's good to see you again. I had a question around, and great talk. We struggle here with our patient portal, and it's probably quite behind the times compared to y'all's. But with even data wise, we have really poor data to know what our utilization is and the demographics of our utilization, et cetera. But on the provider side, as we've kind of scaled up things with the patient portal, obviously the messages and stuff kind of go up too. Have y'all kind of experienced that? I'm sure you have, and just kind of what steps y'all have taken, because our physicians, one of the largest dissatisfiers right now, if you take just documentation out of the picture, is the message center, the patient portal, and the constant bombardment of stuff that they have to respond to.
Totally. Brian states the first of the two collaborators is doing a ton of work in that space. He published a pretty cool study using audit log data to show the pretty profound and directly related with like semi-causal methods to basically show that the 21st Cures Act just massively drove up task load from this perspective. And he is now pivoting a lot to work on things more related to What are the best practices? What are the best ways to pre-counsel patients to avoid that? One of the big things that has come up as sort of the literature has progressed since we've done these studies is pushing vendors as well as local techniques to really try and make people understand that they are required to have access. They are not required to look. They are not required to be notified. There is no reason to have a mandatory default notification setting. The law doesn't say that. It doesn't require that to be done. And so that is one means that we can really leave it to the people who want it. And that can be a person-driven decision rather than an institutionally mandated one. So that's one strategy that's come up as sort of a national scale thing that we can do, assuming the vendors get on board, which of course is an ongoing challenge. I think they're inching in that direction, but inching, not walking or running. In terms of workload burden and burnout reduction and things like that, I think there are opportunities bidirectionally to help in terms of, there's longstanding technology for things like filtering messages in terms of thematic analysis in an automated fashion. And I think, it's only a matter of time before the vendors get on board with that. But I also think that knowing the data structures involved, that's not something that's beyond, if somebody was innovative, you could do that with a Fire app and really screen and say, hey, we've got a high risk message versus, hey, you can probably wait for this one versus responding automatically to the patient saying, hey, you reached out about a medication refill. Are you sure you haven't tried to do this in the portal? There's a feature for that yourself. And giving them a second chance to do that. I think the automatically generated but clinician vetted messages may be an opportunity. And, there is definitely a blind spot that I have, and I suspect you do too, given the nature of the fact that we're both emergency docs, that some of our primary care people would come in and be like, you guys are totally missing the point. So I think partnership across disciplines and making sure that the people with the highest burden are leading some of this is going to be really important to identify the right places in workflow where we can direct those resources.
Yeah, thank you.
Thanks for being here. And I'm happy to stick around, but I do know that the world has gotten to 10:55. So I don't know if we want to sort of give people a chance to hop off. And then happy to stick around for a few minutes if anybody wants to ask additional stuff.
Yeah, we do have 5 more minutes if anybody has any final thoughts, comments, questions. And also you can contact Dr. Turer after this seminar.
I'll put my contact stuff in the chat in case anybody's curious.
But I do like when people say that whole idea of the 25-minute half hour or the 50-minute hour. Although even when people implement that, I find that people kind of have a hard time sticking to it, even though it's good.
I'm the worst at it. I'm like, oh, great, we've got 5 more minutes. You're like, that's not the point.
Yeah, well, at UAB, it's a really big spread out campus. So sometimes people really do need that time to get to the next thing. Although this is a virtual webinar. All right, well, hearing none, I guess maybe we can try to have that extra few minutes to take your break or whatever, get to prepare for your next meeting. All right, well, thanks again for a great seminar. Thank you, everybody, for attending and for questions. And hope to see you at the next Power Talk. Have a great weekend.
Thanks so much, guys. Have a great weekend.
Bye, everyone.